Okay, picture this. The air in the emergency department is just thick with tension. You hear the runner shout, "Child coming in, age 3, history of eating nuts, stridor, wheeze, sats are dropping fast."
The classic nightmare scenario.
Right. And in that instant, your clinical knowledge, it has to fire, but just as importantly, your leadership has to activate immediately.
Absolutely. The difference between a safe outcome and, well, a tragedy,
Yeah.
it's not just about what drugs you give.
It's about how you structure, coordinate, and lead that team under, frankly, extreme pressure.
These are the highest stakes scenarios in medicine. The time you have to intervene effectively. We're talking seconds.
Which means improvisation.
Is deadly. You just can't do it.
Welcome to the Deep Dive. Today, we're doing a really critical review of pediatric emergency leadership. This isn't just theory. We are extracting the high-yield framework.
The non-negotiable steps.
Exactly. All derived from core sources like GMC guidelines and RCUK resuscitation protocols. Our mission is to equip you with the exact structure that defines safe, effective, and ethically sound action in a pediatric crisis.
We're basically giving you the essential playbook.
Yeah.
Every decision we're about to discuss, it scores highly because it prioritizes safety, structured escalation, and really strict guideline fidelity.
Okay, let's unpack this.
Let's do it.
Let's start at the very beginning with the foundational clinical priority. Because pediatric arrests, they follow a really different path than adult ones, don't they?
They really do. And what's fascinating here is that the physiological difference dictates the entire approach.
Okay.
Unlike adults who, commonly arrest from a primary cardiac event,
Yeah.
children typically arrest from hypoxia.
A lack of oxygen.
A lack of oxygen. They have smaller residual capacity, much higher metabolic rates. They desaturate incredibly fast.
So if the underlying cause is a lack of oxygen, we can't just default to the adult standard of, say, 30 compressions, then 2 breaths.
No, that whole approach prioritizes circulation over the fundamental need for oxygenation.
Yeah.
It's the wrong way around for a child.
I see.
Precisely. And that is the key distinction you have to internalize. The core high-yield action, the rule that shows you have that immediate guideline-aligned judgment, is ventilation first.
Ventilation first.
It means the instant you identify the need for resuscitation, you give the initial 5 rescue breaths before you even think about starting compressions. You have to treat the hypoxia first.
And then once resuscitation is underway, that priority is maintained through the ratio itself. Can you walk us through the logic of that pediatric ratio?
Of course. So when you have 2 rescuers there, the recommended pediatric ratio is 15 compressions for every 2 ventilations.
15 to 2.
15 to 2. Now think about the adult ratio, which is 30 to 2. That shift, reducing the number of compressions between breaths, it's a direct reflection of that need to prioritize oxygen delivery all the way through. This guideline fidelity, this whole ventilation-first mindset, is what separates the correct response from the common but incorrect adult default.
Okay, so that sets the clinical priority. But like you said, improvisation is deadly. A highly stressed team, even if they know the 15 to 2 ratio, they're going to fail if they don't have structure.
Exactly.
So how do the sources say we should, tame the chaos right at the start?
Well, the sources stress that structured teams, the ones using recognized pediatric tools, they beat improvisation every single time. And structure begins the moment you activate help.
So the very first action.
The early structure principle, as we call it, is always to activate help and name rules. You have to establish command immediately.
And it's not just about shouting, "Someone take the airway." Right, because that diffusion of responsibility is what leads to errors.
It is. You have to assign explicit accountability to individuals.
And the mechanism for that, for ensuring that accountability.
It's called closed-loop communication. When you, as the team lead, delegate a task, the person who gets the instruction has to repeat it back to you.
Exactly.
And you confirm they're starting the action.
So something like, "Give 5 breaths, Bem."
And Ben says 5 breaths confirming, and you say confirmed, commence.
That simple loop.
It eliminates ambiguity. It prevents dangerous tasks from just being dropped in the chaos.
Let's really nail down those specific mandatory roles that the team lead has to assign out loud.
Okay, so you need 5 core roles clearly allocated. You, the doctor, you should almost always be the team lead, the one calling the shots.
Right.
Then you need dedicated roles for airway and ventilation, another for circulation and drugs, a dedicated runner to fetch equipment, and, this is crucial, the scribe, or timekeeper.
That scribe is the anchor point for all your professional accountability later on.
Absolutely.
So to give everyone listening the model phrase, the gold standard for clarity in those first 10 seconds, what does that sound like?
It sounds like this. I'm team lead. Arsha airway ventilation, Ben circulation drugs, Chen runner, D scribe time closed loop only.
Wow.
That one phrase establishes the roles, the command structure, and the communication protocol all at once. It's concise. There is no room for confusion.
I really appreciate the speed and clarity of that. Okay, let's move from team structure to clinical safety, because once the team is ready, we face two deadly traps specific to pediatrics.
We do.
The first one is all about drug safety.
Yes. Deadly trap one is, without a doubt, dosing errors.
Because children aren't just small adults.
They're not. Their organ systems, their liver, their kidneys, they're immature.
Mm.
Their circulating blood volumes are tiny. Giving an adult dose of adrenaline, for instance, is potentially fatal.
So using adult equipment or adult dosing in a child is a massive red flag.
A huge red flag that demands immediate intervention.
So how does this system mitigate that risk when you're under pressure and you need drugs, immediately?
Strict guideline fidelity is the only way, the only mitigation. This means using pediatric length or weight tapes.
The color-coded ones.
The color-coded ones, yes.
Yes.
And adhering strictly to your local verified drug charts. The sources are absolutely explicit. You must never, ever guess drug doses by eye.
And if you see a colleague doing that?
Your professional duty is to stop the procedure. You have to stop them and correct the dosage immediately.
That makes perfect sense. The safety device, the tape, has to be integral to the whole process. So, deadly trap 2 is misdeterioration. This is relevant not just in an arrest, but in any rapidly sick child.
Yeah, this brings us to the National Pediatric Early Warning System, or PEWS.
PEWS.
This is the mandated tool that's used right across the UK for standardized observation and escalation in hospitals. It takes objective physiological signs, heart rate, resp rate, cap refill time, and it converts them into a standardized score.
So how does the PEWS system actually work for the doctor on the ground?
A high PEWS score is a safety trigger. It's not just a warning, it's an instruction.
An instruction to do what?
When that score hits a predefined threshold, the function is immediate escalation. We're talking immediate calls to the senior team, the pediatric registrar, and critically, the ICU outreach team.
Right. So unlike some adult systems where a high score might just mean, let's monitor them a bit closer.
With a child, a high PEWS score mandates a change in care setting, or at least level of seniority.
So the professional failure here, and the lowest scoring option on any judgment test, would be to wait, to observe, or to try and manage that high PEWS score on your own, especially if you're junior.
Exactly. The doctor must act on the PEWS trigger. Delaying escalation because you're, trying to get IV access or because you think the unit is too busy, that's ignoring a mandated safety standard. You have to escalate immediately.
Okay, let's pivot now to applying these rules in specific high-stakes clinical scenarios, because timing is everything. Pediatric agencies are so reliant on algorithms.
They are. You have to know the core frameworks, things like PLS or PALS for arrest, NICE NG51 for sepsis,
RCUK for anaphylaxis, NICE NG232 for head injury.
Yes, and following those guidelines precisely is the core of guideline fidelity.
Let's go back to that anaphylaxis scenario from the intro, the child with stridor after eating nuts. What's the critical distinction here in terms of treatment priority?
The distinction is about route versus speed. The critical intervention is that intramuscular adrenaline, IM adrenaline, must be given immediately, per the age and weight band.
It's the first-line treatment.
It's the first-line airway-preserving treatment.
And here's the common trap answer we always see. Wait for 5E access before giving adrenaline.
As the team lead, why does that choice just tank your score and risk the patient's life?
Because it delays life-saving care based on procedural difficulty.
Right.
In a shocked child, getting IV access can be extremely challenging and can take a long, long time. Anaphylaxis is a rapidly progressing airway emergency.
So while you're fumbling for a vein, exactly, you're delaying the IM adrenaline, which is quick, effective, and minimally invasive. You're prioritizing a more complicated route over the immediate treatment of airway compromise. You have to intervene with IM adrenaline immediately.
That clear priority IM first, regardless of IV access, is key. Okay, moving beyond the immediate clinical steps, we need to talk about the soft skills. The GMC professional expectations, especially around communication and documentation.
Yeah, these elements are so often overlooked in the heat of the moment, but they underpin all of our accountability and professional conduct.
Let's tackle the sensitive issue of parents at the bedside. They're terrified, they're watching their child receive critical care. How do we manage that without compromising the technical response?
Well, the GMC expects us to involve them where it's appropriate, but we must protect the resuscitation space. The guideline says you have to specifically allocate a staff member.
Ah, a dedicated person.
A dedicated person. Someone who isn't essential to the core clinical team. Maybe a colleague or a dedicated nurse. Their sole task is to support the parents, communicate clearly, update them, answer their questions.
That containment ensures the parents feel involved and respected, but the clinical team can stay focused.
Exactly. Efficient and focused.
We also have to maintain a crucial safeguarding lens throughout all of this.
Absolutely. The sources constantly remind us that if the history from the parents or carers doesn't quite fit the injury or presentation,
You have to think about it.
you must actively consider safeguarding concerns, specifically non-accidental injury. That context has to be part of your assessment. And if suspicions arise, your documentation and escalation need to reflect that awareness.
And speaking of documentation, let's revisit that scribe role and the non-negotiables for the permanent record. What are the anchor points from the GMC here?
The GMC mandates clear, accurate, timely records, that's paragraph 69 to 71, of good medical practice. The scribe's role is essential because the team lead can't possibly record everything. It's too fast.
So they're recording the record of command.
The record of command, yes.
Yeah.
And that record must contain specific details, precise times of every intervention, full details of treatments given.
So route, dose, everything.
Everything. Route and dose based on weight. Also the decisions made and the rationale, precise details of escalation, who you called, when, what they advised, and all key parental communication.
So it's not enough to just write, gave adrenaline.
No. You need 15.35, adrenaline, 0.3 elemental IM, based on Broslow tape weight band green, Registrar Dr. Singh informed at 15.37.
That level of detail.
That level of detail. Because if it's not documented, it didn't happen. And that breaks the continuity of care chain and it compromises your professional defense if the outcome is poor. The documentation has to reflect the structured, decisive leadership that was exercised.
The complexity of blending all of this, clinical rules, procedural safety in such a short window, it really requires a good mental cheat sheet. Let's synthesize everything we've covered using those memory tools from the sources.
Good idea. These mnemonics are designed for rapid recall under pressure. They link the clinical priorities to the safety processes.
Okay, and here's where it gets really interesting. Let's start with the one designed to connect the core clinical steps to the safety frameworks. ABC-PUWS.
Right. So A is for airway breathing. That's your foundational reminder for the initial 5 rescue breaths.
Okay.
B is by-weight dosing, the link-weight tape safety check. C is checklist algorithms adhering to PLS, NIE, or RCUK guidance.
P is PWS triggers.
The immediate escalation mandate, yes. E is escalate, calling the PS registrar and ICU outreach. W is work with parents.
By allocating that dedicated supporter.
Exactly. And finally, S is scribe document, the final layer of accountability.
That's a great one. It covers the clinical and the procedural checks. The second one, Kids Lead, focuses more on the leadership and organizational steps.
That's right. K is call early, don't delay activating senior help. I is ID roles, using that closed-loop communication model. D is drugs gear by weight, another reminder of that dosing safety net.
S is support parents. L is look at PUWS.
E is escalate. A is algorithms. And D is document. The two tools, they overlap strategically to make sure that in the chaos, you hit every single high-yield, GMC-compliant action point.
So if you can run through those checks in your mind during an emergency, you've pretty much covered the high-scoring elements of structured, safe, and GMC-compliant care. Let's just quickly recap the 4 core takeaways from this deep dive.
Okay. First, prioritize ventilation first. You always give those initial 5 rescue breaths before starting compressions in a child because of the high risk of hypoxic arrest.
Second, dose and size by weight length tape. Get out of the habit of eyeballing doses and rely on the mandated safety checks to prevent a catastrophic error.
Third, escalate using national PEWS thresholds. A high score is an immediate trigger for senior pediatric or ICU involvement. Delaying that escalation is a professional failure.
And finally, lead out loud. Assign those rules using closed-loop communication and make sure the scribe documents times, treatments, decisions, and parental communication. Precisely.
Exactly. You know, we've Spent this entire deep dive focusing on the intense micro-leadership required for a single critically ill child. But the principles, structure, clarity, communication, they have to scale up.
What do you mean?
The sources mention using the methane framework, which stands for Major Incident Communication for Larger Events. So, if rigid, structured leadership is mandatory for managing one child, you have to ask yourself, how does that need for structure translate when the scale explodes?
When you're coordinating multiple teams across multiple casualties,
Exactly.
that's a profound challenge. The cognitive framework for micromanagement is really the foundation for mass casualty response.
It is. So I'd encourage you to explore that methane structure next time you consider leadership frameworks. Recognize that the clarity you establish in a trauma bay for one child is exactly the clarity required at a macro level.
Keep striving for clinical excellence and structured leadership.
You've got this.